I'm Amita Mahajan. I'm a pediatric oncologist at Indraprasth Apollo Hospital, Delhi. I've been working in the field of pediatric hematology oncology within the Apollo group for over 2 decades now, and have personally, seen the transformation that the world of pediatric oncology has seen in these 2 decades, and how we are able to give the best possible care to each and every child that we treat in India at a fraction of cost that's given in the Western world.
My name is Dr. Revathi Raj and I work at the Apollo Hospitals in Chennai. I have been practicing at the Chennai Center now since 2002, and the amount of progress we have seen within the Apollo group and especially in Chennai is mind-boggling and amazing, especially in the field of transplantation and hematopoietic stem cell transplantation for children. The advances have been immense. We have brought into the country the first unrelated cord blood transplantation, haploidentical transplantation, and novel cellular therapies like CAR T cell therapy for children. And I must say that the journey has been enriching for both our patients and for us in this field with the Apollo group. So, my expertise is in the field of leukemia, and we have the best way forward for children with childhood leukemia. If it means a rapid diagnosis, including techniques like flow cytometry, PCR, FISH, and supportive care with trained nursing team, infectious disease specialist who can provide support for dangerous bacteria or fungal infections these children have, and to precisely detect their measurable residual disease and to give individual treatment to children. So at the moment, between the Delhi group and ourselves, the outcomes for childhood cancers has been above 85% survival in children. And in addition, I think novel techniques like using immunotherapy, advanced immunotherapy, and transplantation, and techniques like natural killer cell therapy to improve outcomes have also been used in our system. So every child is a walking encyclopedia for us. We learn from them and we try to do better and to individualize their therapy for the best possible outcomes.
So I work in Apollo Delhi, and what's been unique about working within the Apollo, the infrastructure is that we all work as a team. As oncology has transformed, but our hospitals have kept pace with this transformation. And at our request, or whenever we've asked for the new diagnostics or therapeutics to be available, the hospital system has been very amenable to make that possible, keeping us ahead of the curve all the time. We also, within hospitals, not just within the hospitals, but across our group, work as a team. For example, for the children with cancer, on a regular basis, we do pan-Apollo virtual tumor boards, where if I have a difficult case, I can discuss it within that week with a whole group of pediatric oncologists, surgical oncologists, radiation oncologists, and BMT specialists, allowing me to make the best possible decision for an individual child and to actually deliver that treatment. This therefore has been very rewarding because we feel that there is, we don't need to send patients anywhere. Together with each other's expertise, we can offer the best possible care to them in a multidisciplinary environment. Within all our centers, we have backup from all pediatric subspecialties. It is a luxury and it is a rarity. But to have nephrologists, gastroenterologists, intensive care specialists in the field of pediatrics with you as backup is exceptional, and that's been very helpful in achieving the outcomes that Dr. Revathi just pointed out.
So with childhood acute lymphoblastic leukemia, the first step is to give them all risk stratified based treatment so that the number of children who are going to relapse and who need transplant is reduced. So in our own series, if we treat 10 children, only 1 or 2 of them will relapse. So only these are the children that will go for transplant. So we are focusing on reducing the number of children going to transplant so that their outcomes are better with chemotherapy. The ones who we transplant, if they have relapsed after chemotherapy or if they are resistant to chemotherapy and the disease cannot be cleared. What advance we have done now is adding immunotherapy before the transplant so that the outcomes are better. So they go through 4 to 6 weeks of immunotherapy before their transplant. And for vulnerable children, we have also added total marrow and lymphoid radiotherapy because we want to reduce the long-term toxicity but not reduce their survival. So TMLI is pioneered as part of the transplant service for children with ALL. So nowadays, anyone who needs a transplant can have a transplant because we are not really looking at whether they have a matched sibling donor or not. With the families getting smaller and most families having only one child, the chance of having a fully matched donor within a family is only 30%. So the other 70% of the children who need a transplant, we have access to international and national donor databases. So we perform a search, and if there is a fully matched donor available, that is our second choice. And then the third choice, about 40% of the patients would be a half match family donor. So it can be one of the parents or the brothers or sisters, which is called haploidentical stem cell transplant. And we have looked at our 20-year ALL data, and the advances are such that with our services, a half match family donor is as good as a matched unrelated donor or a matched family donor these days. So there have been a lot of advances for ALL patients, especially the ones with BALL. TALL, we are still not so ahead, but with the BALL children, we are able to offer them novel immunotherapy like blinatumomab and inotuzumab before transplant. When they undergo transplant, we try to reduce the side effects by giving targeted radiotherapy, which is called TMLI. And the supportive care definitely has increased dramatically. And we have pioneered a technique of giving a drug called N-acetylcysteine to reduce side effects. And our nursing team with regard to mucositis and infection control team with regards to infections that can happen to a transplant patient. And most importantly, after the child is discharged, we have to meticulously follow up for signs of relapse and intervene before they relapse. So the follow-up period of 2 years to keep an eye on them and to make sure that the child doesn't relapse is where most of the focus is on now. And we are doing a number of interventions to prevent relapses in these patients, including the use of newer cellular therapies. So our motto right from the beginning is no matter what socioeconomic background a child comes from, we have to offer treatment for all of them, and it has to be the same treatment that any other family who comes from a higher socioeconomic background would have. So we're not deciding different treatments for different children of lower socioeconomic and higher socioeconomic groups. So they're all given standard of care. And I think I speak for both Amita and myself. Over the last 2 decades, we have partnered with a number of NGOs who work in the field of childhood cancers. There's Leukemia Crusaders, Can Kids, and we participate in and encourage families to do crowdfunding. So whatever it takes to get the amount required for them to have their treatment and to complete the treatment. And abandoning treatment for the sake of money, our abandonment rates are very, very low. With Tamil Nadu, we are very fortunate because the hospital has partnered with the CM scheme, and all our below poverty line children also get access to care.
So Hodgkin lymphoma is not that common a cancer. In fact, all of childhood cancer is not that common. Where Hodgkin lymphoma stands out, that it is perhaps the most curable condition in children with cancer, and also that its treatment has virtually transformed in the last decade, and we may be approaching an era where we may be able to successfully treat these children even without any chemotherapy. So to date, our standard of care has been conventional chemotherapy with a proportion of children needing radiation. We've worked as a community very hard to reduce the number of children that require radiation, because radiation is the one treatment modality in young children that can lead to lots of problems when they are adults, or even in elderly age group. So we've worked very hard to reduce radiation, but in the last decade the introduction of monoclonal antibodies and immunotherapy, which have transformed virtually oncology, but most significantly Hodgkin lymphoma. This pioneering work, which we are also in a position to offer to our patients, that's what's changed Hodgkin lymphoma and is literally leading the way in terms of new ways to look at cancer treatment. So the chances of relapse depend on what is the stage of the disease at the time of presentation and the quality of treatment, whether the child receives optimal treatment or not. So if you have early stage disease, you have about 10% chance of relapse, while if you present with advanced stage disease, you have about 20-25% chance of having either relapse or refractory disease that doesn't respond very favorably to frontline treatment. So for we luckily both of us work in units where we are a part of a team with pediatric oncologists, adult oncologists, surgical, radiation, psycho-oncologists, and other people who may specifically look at long-term toxicity of the treatment that they may have received. So for us, it's not an issue. We would, and the treatment is brief, so it would always be completed in a matter of months. But yes, like you pointed out, these children need follow-up for life. But more than follow-up, it is vital that when we are planning and delivering treatment, we keep the reduction of late effects as one of the very important treatment goals. So it's not just about cure; it is for minimizing the price that we pay for that cure, and also balancing the price that we pay. So this is a juggling act that we have to do for every patient. And like Dr. Revathi pointed out, with governmental, non-governmental support and crowdfunding, there is no reason why every child in India should not be able to get optimal treatment. So the most promising area that we currently know is immunotherapy or immune checkpoint inhibitors, which looks to be paving the way to reduce chemotherapy more and more, and using these agents which have very little short-term toxicity. Their price is an issue at the moment, but in India, pioneering work is being done to see how we can lower the cost. Perhaps a lower dose may be equally good, and it's just a matter of time that we have these products being produced in India. So I think it is really, if we look at Hodgkin lymphoma, we are kind of changing the way we treat almost every year, because the guidelines are changing so fast, the field is changing so fast, and I envisage that how I am treating today is very different from how I will be treating 2 years from now. So it's a field that there's so much dynamic improvements happening, all patient oriented and patient focused, improving cure rates, reducing the price that we are paying for that cure. So the Apollo Cancer Conclave, since its inception, has been a unique opportunity for us to meet the specialists, the people who are doing transformational work within India, but also from across the globe. And each year we've seen that the quality of discussions, the speakers, the level is increasing, and it's now an academic meeting to be reckoned with, where we actually come to learn from each other, from others that we may not have heard before, and it's really a wonderful experience. This particular conclave, I think, has a very high content of both scientific and in terms of organizational issues. My experience has been wonderful so far.
I think the first Apollo Cancer Conclave we did in Chennai, and the current one, the amount of science and the amount of interaction both within the country and outside of the country, it's an amazing leap. Every time we have the cancer conclave. It brings out what is best in the country and what is best in all over the world. And especially, I think the cancer conclaves have always had a specific focus on the African countries and to bring our partners from there as well to engage with the physicians within the Apollo group. I have always enjoyed the cancer conclave both for the hospitality and for the science, and I think this would be a conference for the future for young people within the system to look at mentors, to look at what's happening across the world and do better within the Apollo system.